First, we had our skin, which we took off. Upon taking off the skin, we found that we had a superficial fascia. And the superficial fascia had two layers. There's a fatty layer, and then there's the membranous layer. The fatty layer is Camper's fascia, and the membranous layer is Scarpa's fascia. We also found that it was very easy to dissect. In between the superficial fascia and the aponeurosis of the abdominal wall muscles, that's external oblique, there's loose connective tissue, and it's very easy to dissect it in this inferior area below the umbilicus. But then the dissection cannot go downwards below Holden's line, which is just slightly below the what? Below the inguinal ligament. And we saw that that was very important, especially when it comes to trauma to the urethra leading to extravasation of urine. We also saw that even if the loose connective tissue ended at Holden's line, however, the plane continues deep into the perineum, and we could follow it with our fingers, and we found that there's loose connective tissue that we could easily pass our fingers through. We went ahead to dissect. We identified several cutaneous branches of the subcostals and intercostals, which we may not be able to appreciate so much right now because we have taken them off. And then we went ahead to dissect the superficial fascia from the anterior abdominal wall muscles. Immediately, we got to see the external oblique muscle, whose fibers are running and inferomedially. Yes. And we saw that some of its origin is from the costal, from the lower ribs, the costal cartilage, and we also found that the fibers were interdigitating with the fibers of serratus anterior, which we managed to dissect off. We followed its origin all the way posteriorly, and at that point, I think we came down to our inguinal region. We were asked to identify the superficial ring, and we found the superficial ring in between the medial crus and the lateral crus of the external oblique. We also found that the external oblique aponeurosis went and curled back upwards to form inguinal ligament, which we were able to palpate and appreciate, which is a condensation of the external oblique aponeurosis. We also appreciated that it's mostly muscular, but as it approaches the midline, it becomes aponeurotic, and we found that it's simply fibrous tissue. Coming back to the inguinal region, we were able to identify the spermatic cord, which we found it to be this. We were able to identify the lateral crus of the this is lateral. This is the lateral crus. We identified it, and we saw how it attaches to the tubercle. And upon identifying its attachment to the pubic tubercle, we were able to identify also our lacunar ligament, which we best appreciated by looking at it from down here. So our ligament is here, and at this point, we have our lacunar ligament right there, which is holding it down onto the pubic tubercle, but also along the pectineal line. Yes. All right. So that we did, and that was the last thing I think we did last week. So today we came back to recap, and we managed to see that, but then we continued medially to identify our internal. Let us take away the external oblique. We got our internal oblique muscle, and we could see that the fibers are running perpendicular to the fibers of external oblique. So these are running this way, and these are running upwards. And we followed it all the way down such that we could find the fibers of the internal oblique, which were contributing to the cremasteric muscles. And if this is our spermatic cord, we could see pieces of muscle that are coming off from the internal oblique to form the cremasteric muscle of the spermatic cord. From there, I think they took us all the way back up, and then they brought us to the conjoint tendon. But we can look at the conjoint tendon. So, after looking at the internal oblique, we were able to find the transversus abdominis, which was very difficult to separate from the internal oblique. And in the plane of the transversus abdominis, the plane in between the transversus abdominis and internal oblique, we were able to identify certain nerves. We followed the internal oblique and transversus abdominis medially, and we found that the fibers merge and they form an aponeurosis, which inserts as our conjoint tendon, and we were able to see our conjoint tendon right here. And the conjoint tendon is forming part of the posterior wall of the inguinal ligament, but more medially. Yeah? Okay. From there, we could also probably look at our transversalis fascia, but first we have to identify it. So after the transversus abdominis, we were able to look at our transversalis fascia, which is this very thin coat, and we could follow it all the way downwards to where we have our deep inguinal ring. Cunningham asked us to pull against the spermatic cord to see the continuity of the cord with the transversalis fascia. And that's because the transversalis fascia is what gives us the internal spermatic fascia. Okay. And we saw that. Yes?
Were we able to appreciate the iliopubic tract? Dr.
Yeah?
Is the iliopubic tract just theoretical? It's hard to separate from the inguinal
Cunningham
ligament?
did not talk of it in the previous lecture. They didn't mention it, and I didn't want to bring problems. But the iliopubic tract, whereas the inguinal ligament is considered to be a condensation of the external oblique aponeurosis, the iliopubic tract is considered to be the analogous to the inguinal ligament, but it's a condensation of the transversalis fascia, so it's on the other side. Yes, they run together as. So I think we are done with what we did in this region for today. So we went on further to look at our rectus abdominis muscle, and rectus abdominis muscle, we identified it in the midline. First thing that we were asked to do was to open up the rectus sheath over the rectus abdominis muscle, and we did this, and we were able to first of all experience the difficulty in dissecting the rectus sheath over tendinous intersections, but it was very easy to dissect over other areas, and we identified 3 tendinous intersections, of which you could see that there was one tendinous intersection there, then there was a second tendinous intersection here, and then there's a third tendinous intersection right here.
Corresponds to 6 packs.
Yes, which corresponds to the 6 packs.
That voice in the one, so it's
However, we were told that posteriorly we do not have tendinous intersections, and this is very important to allow passage of the superior epigastric vessels, which Katerega found for us right here. So this is superior epigastric. Superior epigastric is a continuation of the internal thoracic, and it anastomoses with our inferior epigastric, which were managed. So we managed to find them in that area. Going back to the rectus sheath, we are able to see that the external oblique aponeurosis merges with the anterior lamina of the internal oblique to form the anterior rectus sheath, which runs anterior to the rectus abdominis muscle. And posteriorly, we're also able to see that the posterior lamina of the internal oblique merges with the aponeurosis of transversus abdominis to form the posterior rectus sheath, and we could see anterior and posterior. However, inferiorly, in the region midway between the umbilicus and the pubic symphysis, we found that at the line midway, the rectus sheath are only visible anteriorly, whereas above that line, they are both anterior and posterior. And we call that line our arcuate line, which you could see after reflecting the abdominal wall inferiorly. So this is our posterior rectus sheath, this is our arcuate line, and then inferior to the arcuate line, you find that the rectus abdominis muscle is in direct contact with the transversalis fascia. Okay, and I think that we had covered up to that point, right? We are then asked to divide the rectus abdominis muscles and to reflect inferiorly and superiorly. And we were able to identify our parieto-peritoneum. And with the parieto-peritoneum, the thing that was very special about it was this. First, we started by identifying this. So there was a midline condensation, which we were told that is a remnant of the ductus, was it? Not ductus, umbilical vein. Yes, umbilical vein. Forms the falciform ligament. It merges with the falciform ligament, but it forms the ligamentum terrae. And we could see the falciform ligament right there. Inferiorly, however, we could identify about 3 condensations,
Better seen with light.
which was best appreciated with transillumination. So in the midline, we saw the median umbilical ligament.
You have to move this.
Okay.
You have to move this side.
Okay. So midline, we saw the median umbilical ligament, and
Which is
then
a
that,
remnant?
which is a remnant of the urachus. Then lateral to it, we saw the medial umbilical ligament, which was much better appreciated on the right-hand side of the patient, and you could also feel it with ease. And then further lateral to it, not very well seen, but we could appreciate this condensation at the lateral umbilical ligament, which you could also palpate. The medial umbilical ligaments are remnants of the umbilical arteries. Okay. And that we saw. So we put this down. At this point, we went all the way up and we were able to identify the attachments of the diaphragm onto the xiphisternum and onto the costal margin, from which we detached it because it was attached to the costal margin and the xiphisternum. We were also able to identify the attachment of the transversus abdominis muscles, which more superiorly correlates very well with the attachment of the transversus thoracis, especially the sternocostallis, which you could appreciate very clearly in that area. And then we reflected that down as well, right? Okay. From here, where did we go?
Yeah, I think that's it. You guys wanting to go deeper?
Are we going deeper?
Stop it.
You can stop there.
All right.
Thanks. Our surgeon.